Well, thank you so much again for the invitation, and I want to especially say thank you to Summer, who introduced a lot of these concepts in her great talk, and I too stayed quite involved, well until the end, but I am partial to this topic also, so I have to admit. Okay, so I'm going to talk about interventions in metabolism in pulmonary arterial hypertension. Are there any trainees in the room? Anybody who's like a fellow? You are? This is the first time, I'm just going to tell you, I've ever put up there the Elsa S. Hannigan chair in pulmonary medicine. I got a chair last week. And I just want you to know, it's possible. I never thought it was going to happen to me. So I just want to tell trainees there's like hope. You can do this. Sorry for indulging me in that. Okay, so I got interested in metabolism in pulmonary vascular disease years ago when I had a fellow, Meredith Pugh, who now directs our pulmonary fellowship program at Vanderbilt. She came to me and said she wanted to work with me and wanted to do a very clinical study. So I said, okay, great. Recently, Ivan Robbins had published that we had a lot of metabolic syndrome in patients with group 2 pulmonary hypertension, but it looked like there might be a signal in group 1 PAH also. So Meredith came to the clinic, and I had no money back then, and she just measured hemoglobin A1C in all comers with group 1 PAH coming to our clinic. And she was very lucky and was able to show that our hypothesis was correct. There was evidence of glucose intolerance in unselected PAH patients coming to clinic. We excluded anybody who had a known diagnosis of diabetes or was taking anti-diabetic medications for anything. And so it was actually a pretty high prevalence. So normal is shown in green on this histogram, glucose intolerance in yellow, and we actually picked up a couple of people whose hemoglobin A1C was over 5.7 and were characterized, over 6, and were characterized as having frank diabetes mellitus. And this sort of came on the heels of work from Roham Zamanian at Stanford suggesting that there was insulin resistance, not just glucose intolerance, in PAH patients. So we then had a study funded by the NIH to look at this in more detail and did a detailed metabolic phenotyping on a cohort of patients with PAH and controls. And what we did was had them come in and do oral glucose tolerance testing, and we measured HOMA-IR, which is an insulin and glucose cross product. So normally they're both pretty tightly regulated, so you shouldn't have abnormalities. And what we found was that, in fact, when you do oral glucose tolerance testing, PAH patients here and controls, there actually was not any difference in people who met criteria for glucose intolerance. And then when you looked at HOMA-IR, this insulin and glucose cross product, it was actually lower in the insulin-resistant patients, in the PAH patients than it was in the controls. So that really kind of made me doubt the hypothesis. But then, we looked at the triglyceride to HDL ratio, and we found that if you define insulin resistance in this lipid-based metric, the triglyceride to HDL ratio, that the patients were indeed almost all insulin resistant and significantly higher proportion than in the controls. So this got us thinking that it's really lipid abnormalities that define insulin resistance in PAH patients, not glucose abnormalities. And this work, is something that was really started years ago by Gustavo Heresy and the group here, who published lipid profiles in patients with pulmonary arterial hypertension, and then followed that up by detailed metabolic testing using a hyperglycemic clamp procedure where patients are admitted, I assume you do it here, you admit patients, and administer IV glucose and measure what happens to pancreatic insulin secretion. And I think one of the most interesting findings from this publication was that in their fasting metabolism, there was higher ketone production, higher lipid oxidation, but insulin wasn't significant. And it looked like the insulin glucose homeostatic mechanisms were working pretty okay in these patients, again, getting at these abnormalities in the lipid axis in PAH patients. There are certainly abnormalities in glucose, and previously Dr. Farha talked about the glucose uptake in PAH patients in their right ventricle, and this is a patient of mine who had a lung nodule that I sent for a PET scan, and I actually just picked out the picture of her heart. You can see this intensely FDG avid but enlarged right ventricle. And so we knew from publications from folks here and also at Vanderbilt that there was glycolysis that was increased in the right ventricle PAH patients, which is sort of weird because in normal conditions, cardiomyocytes prefer to eat fat, that they really generally are mostly fat consumers. Our group had previously shown that fatty acid oxidation was reduced in PAH endothelial cells, so we then hypothesized that if there was impaired mitochondrial oxidation and lipids were not being consumed, and they would accumulate in cardiomyocytes. And so Samer went through this slide previously, showed the actual data, but this is what we now understand about cardiomyocytes. They have more fatty acid delivery, in part because of the data that I showed you. They uptake more through CD36, and they have greater long-chain fatty acid stores. We also have recently shown that carnitine import into mitochondria is impaired, and this ultimately leads to the triglyceride accumulation that was shown previously in ceramide and RB dysfunction. So having shown these abnormalities, it begs the question, well then, can correction of metabolic disease improve PAH? And I had a patient around the time we were thinking about these issues who was, and I love her, but she's incredibly stubborn. And she came to me and said she was going to have a gastric bypass no matter what I said. And she had already conspired to get it done. And I was like, but I'm afraid you're going to die. So I'm not advocating for anybody to have gastric bypass with PAH. But having said that, she was adamant that she didn't care what the risks were. She was going to have it done. And so she did. And so we measured blood levels in her of HOMA-IR, which is that insulin resistance metric, and it did improve, but it was never markedly abnormal. But what did happen was that her BMI, you can see in the black line, she lost weight, but it wasn't like she went to normal. Even today, her BMI is in the 40s. But she did have a marked improvement in her cardiac output and a reduction in her pulmonary vascular resistance, which is kind of the opposite of what you would anticipate would happen with weight loss. And I'm not a cardiologist, so I always get really nervous about showing echoes because I don't know how to, I don't even know how to work them. But anyway, Evan Britton did this for me, and you can see pre-bypass her enlarged right ventricle, and then this was just 1 month after bypass, so before we even remeasured her hemodynamics, she had a pretty marked improvement in her RV function, and this was before she lost any significant weight. So it got us thinking that metabolic interventions, of which this is the most extreme form, may be valuable in PAH. We were not the only people to have this idea. Around this time, Evangelos Mikalakis, building on a large body of literature showing that there was impaired PDH activity in patients with PAH. So normally, pyruvate is converted to acetyl-CoA with this enzyme PDH as it enters the mitochondria. And normally there's sort of reduced PDH activity in PAH, so that they hypothesize is what underlies mitochondrial dysfunction. Using this dichloroacetate, you can essentially take off the brake on PDH and enhance mitochondrial respiratory capacity. And so therefore there should be less proliferation and less vascular remodeling. Well, they proposed a trial of DCA, which also has been used in cancer treatment. The primary endpoint was safety and tolerability. They were on a number of different therapies for PAH, you can see here. Ultimately, there were no significant adverse events, but 4 out of 5 patients withdrew because of severe peripheral neuropathy. So it looks like this drug is probably not going to move ahead, but they were able to find that there were certain genetic variants in mitochondrial function that predicted response. Again, sort of getting back to this idea of precision medicine, like maybe there's a specific metabolic phenotype that would benefit from DCA. I'm not aware of anybody pursuing any further studies of this based on the challenges with tolerance. So that's looking at the glucose system. We were interested in the lipid metabolic system. We have a rodent model of heritable PAH that expresses a BMPR2 mutation diffusely, including in cardiomyocytes. And because of this lipid abnormality, you can see they have oil red O staining in their cardiomyocytes. When we gave these mice metformin, you can see that the red stain basically completely goes away. And that's quantified here. But also by invasive hemodynamics in the mice, the one thing that did get better was tau, which is a marker of diastolic function. So we thought there might be some improvement in right ventricular function with metformin administration. So we got funding from the NIH to do a study of metformin. It was an 8-week open label dose escalation study, no placebo. You can see the NCT number. And patients kind of had a standard evaluation, but the one thing that we did add was in a portion of patients, we used MR spectroscopy to measure lipid content, and that was at day 0 and then day 56. The primary endpoint was safety, and then we also measured change in urinary plasma and F2 isoprostanes as markers of oxidant stress. When you apply to the NIH for a grant, you apply when you're thinking is at time A, but then, 3 or 4 years later, your thinking might be time B, and you wish you had a different secondary endpoint, and that's kind of what happened in this trial. We've evolved our thinking, and I wish we had picked RV lipid, but that's not what we did. The secondary endpoints are change in cardiac MR spectroscopy, lung, FDG avidity, and C11 acetate, which we're still actually analyzing now. These are the baseline demographics of the patients. You can see they're mostly heritable. Well, they have, a pretty decent percentage of heritable and idiopathic PAH. We did not include any scleroderma patients or connective tissue disease in this initial study. They were on pretty sick, so half of them were on prostacyclins. You can see their baseline lipid data and their obesity scores and their hemodynamics. There was no signs of a safety problem with them. Some patients had diarrhea, as you'd expect with metformin. Here's what was interesting. There was no difference in isoprostanes or isofurans, no difference in 6-minute walk distance, but there was an improvement on echo of RV fractional area change with other echo metrics that were not statistically significant, sort of pointing in the same direction. And I think that speaks to how granular fractional area change is versus TAPSE, and how you might incorporate that in future study planning. But it did look like it improved RV function. And then there was a significant reduction in the patients who did MRI of RV lipid content. So you can see there are some people who are way outside the normal range, even diabetes and obesity, they're way abnormal, and they had improvement that was statistically significant. And then we looked at plasma metabolomics to look at which metabolomics correlated with improvement in RV lipid content. And you can see some that are up here that came out. The one that I think is really interesting is N-acetylputrescine, which I had not particularly anticipated coming out, but has been published to correlate with outcomes in a whole separate UK cohort. So it's sort of an interesting and growing sphingolipid metabolite that may be of mechanistic relevance. It also reduced FDG uptake, and we need to publish that. We're working on that now. And in the last little bit, I wanted to talk about physical activity in pulmonary arterial hypertension. Again, going back to Meredith Pugh when she was a fellow, we got the idea that that patients with PAH probably have reduced free living physical activity. And it sounds crazy, but in 2012, people weren't really measuring this all the time. Some people had Fitbits, but it wasn't like a all the time thing. And so we just gave patients accelerometers and measured what they did with activity. It was not surprising to find that our patients had reduced free living physical activity. You can see the PAH patients in black. They had reduced total activity, but also essentially no vigorous and hardly any moderate physical activity. And moderate would be characterized as things like vacuuming. It's not really all that intense physical activity. So the patients are really impaired in their daily life. And then if you look at percent of time spent at low level, 1 to 1.5 METs, PAH patients were markedly higher than control. So they're highly sedentary patients. So in thinking about insulin resistance in this story, we talked about it with our endocrinology colleagues, and they said, well, one of the ways that you can make even the fittest person insulin resistant is to strap them to a bed and tell them they can't move. So physical inactivity essentially is tightly associated with insulin resistance. So we were interested in whether if we improved physical activity, we could then improve insulin resistance in our PAH patients. It seemed like a relatively low-risk intervention. We were not the first people to think about this. Other people had. And in fact, there's publications from a German group in which they admitted people to the hospital and did a 6-week exercise program for several hours a day, they can improve 6-minute walk distance to a greater degree than we can with any of our drugs that are available today, which you can see here. I need to add some of the newer drugs. But anyway, suffice to say, the point is 6-minute walk distance can be improved by exercise. So that led us to wonder whether exercise might be a mechanism to improve insulin resistance and quality of life in patients. The problem is, I don't know about life at the Cleveland Clinic, but at Vanderbilt, it's very hard to get people into pulmonary rehab. And I can tell you the number of people that I've admitted to the hospital for 6 weeks for physical therapy in the last 20 years of doing this, it would be none. So it just doesn't happen. So we had to come up with a way to do this. And credit to Evan Britton, he paired with a group who used a text-based intervention to do this as outpatients. The group's from Hopkins, and it's Mike Bleha. And what they did was they randomized patients with PAH to usual care, where we just said exercise is good for you, basically, or a text-based intervention for 12 weeks. And everybody got, in the intervention arm, 3 automated text messages a day, including real-time daily step counts and encouraging messages that were rooted in some behavioral change theory. And the messages kind of were personalized to each patient. So there's 3 people who do pulmonary hypertension care at Vanderbilt. And if you were my patient, it'd be like, Dr. Hemnes, thinks you would benefit from a nighttime walk after dinner. Why don't you consider walking your dog? Like if I knew you had a dog or something. So it was very personalized text messages. It's not just you got to walk more. So. And it was kind of well done. The patients, let me tell you, this was the easiest study we've ever enrolled in. Patients loved this study. So you can see one thing that Evan did that was very smart was he had a 2-week run-in period, and it's not shown on here, but I love these data. So everybody, when they had a Fitbit, started walking more, and they walked more for exactly 1 week, and then everybody went back down to the baseline. So there is a Hawthorne effect, and it wears off after 7 days. And then he started the text intervention you can see here. The treatment group is in blue, and the usual care is in yellow. And the treatment group got a higher percent change, or a higher change in raw steps, so 1,400 steps per day more versus the usual care arm that actually went down in their step count. And it persisted after adjustment for age, sex, baseline step counts, and functional class. There was it was a sustained improvement in change in 6-minute walk, essentially throughout the entire trial, or not sustained in activity counts, sorry. Secondary endpoints suggested that there was an improved quality of life in the EMPhASIS 10 score, and I was particularly interested in actually a significant reduction in visceral fat volume, and a trend with a P of 0.051 to improved right ventricular function as measured by TAPSE. So the takeaway from this was that you certainly can, by a behavioral intervention, improve step counts in PAH, and secondary endpoints suggest that you may be improving metabolic disease in PAH as measured by visceral fat volume. So we're now have an ongoing study of more advanced text message intervention in PAH patients that I'll get to in a second, but that was pretty exciting. So here's some candidate metabolic pathways and drugs. So we talked about glycolysis, and the DCA drug, I think is probably not going to move forward. Enhanced mitochondrial respiration, we talked, Dr. Marin talked this morning about bartoloxone, and that may move forward. We'll see what happens with the phase 2 trials. Fatty acid oxidation, I gave you my pitch for metformin. I've recently been really interested in glucose uptake, and we have been thinking about GLP-1 receptor antagonists, or agonists, I should say. I need to correct that. Right ventricle changes in metabolism. So there is controversy in the topic of right ventricular fatty acid oxidation and what to do about it. It's not controversial that it's reduced. Some folks think that we need to further reduce it and promote glucose oxidation. Other people like me think we need to promote fatty acid oxidation. So if you're in the reduce fatty acid oxidation camp, then you're curious about the results of ranolazine and trimetazidine trials that we've been waiting for and I think have kind of stalled. I showed you our data from metformin. There's glycolysis may be effective in the right ventricle as well via DCA, but again, it's got the neuropathy problems. And then, the big question in the room is the SGLT2 inhibitors, and whether they may be of value not just in group 2 pulmonary hypertension, which is also not proven, but whether they may have a role in PAH and metformin again. So future directions. We are now enrolling with the folks here at Cleveland Clinic and also at Mayo Clinic in a multi-center trial of interventions against insulin resistance in PAH. We were able to reduce our sample size needed to 100 patients, and I think we're in the low 80s right now. So we're getting there, limping to the finish line in the pandemic. And the trial is factorial design. It's metformin or placebo, or a mobile health-based text intervention versus placebo to change walk count. So you can see there'll be people who are getting both interventions, and you'll see if the 2 interventions are synergistic. We are also looking at mechanistic studies of how lipid accumulation promotes RV failure, and Evan just had a R01 funded to study that. I'm really interested in specifically how these mutations associated with heritable PAH, like BMPR2, can actually cause mitochondrial changes. And then, as I mentioned, studies of new anti-diabetic agents are certainly of interest to me and others. So I got a different set of acknowledgments on this one, and I'd really like to thank James West and Evan Britton and Eric Austin, who have been my colleagues for a number of years studying this. And way in the back is John Newman, who used to get the Elsa Hannigan Chair, but he retired this year, sadly, so it's now mine. So thank you, everybody, for your time and attention.